ENT conditions. So there is always a dilemma among all the medical fraternity as to what exactly the ENT surgeons do. So is it a medical subspecialty or is it a surgical subspecialty? So I would like to say that it is a niche subspecialty, and there are several conditions where the problem can be treated medically, some conditions only surgical option, and a lot many conditions where both medical and surgical treatment is possible.
But the 90% are medical?
No sir. No sir. No sir. I'll just go ahead. So it's a niche specialty, and but many conditions are not uncommon. So what is our main equipment? We need an otoscope. So otto is ear. So otoscope is for examining the ear. We need a torch or a headlight to examine the oral cavity, the nasal cavity. We need a tongue depressor, a nasal speculum, which is the commonest one is the honeycomb nasal speculum, artery forceps, and the probe for seeing the ear. Now, what is
that nasal scopy doesn't come as a part of routine exam?
So we do an anterior nasal scopy with the nasal speculum, that is the honeycomb nasal speculum. We can do an anterior nasal scopy. So we can see the turbinates, we can see the mucosa, we can comment about whether there is any infection, whether there is any allergic problem, whether there are any polyps, just by doing an anterior rhinoscopic examination. But if you want to see the entire nasal cavity, the anterior nares, the posterior, going up to the eustachian tube and the posterior pharyngeal wall, you need a flexible scope or even a rigid scope. So this is what the normal ear looks like. It's a little blurred, but I'll explain it in a little detail. So we have the three parts of the ear: the external ear, the middle ear, and the inner ear. And the auricle or the pinna is the outermost part of the external ear. So this, the upper part is cartilaginous, and the lower part, which is called the lobule of the ear, where the ear piercing is done, it will not have any cartilage. So the upper part is known as a helix, and then something inside which is called the antihelix. And there is a Y-shaped distinguishing, which is the superior crust and the inferior crust of the helix. And then you have something which is known as a tragus, which is this point, and then opposite to the tragus is the antitragus. And then you have the hole, which is known as the external auditory meatus. Okay. And then the external ear is the auricle, the external auditory meatus going into the external auditory canal, and then that is the end of the external ear, and then when the tympanic membrane starts, that is a part of the middle ear. So this is how a tympanic membrane looks like. So it is a translucent, pearly, white membrane with it's got three parts. The external part is a layer which is continuous with the skin of the external ear. Then the middle part is a fibrous layer, and then the inner layer is continuous with the middle ear, and that is the middle ear mucosa. So this is a translucent membrane, and we can see a lot of things and diagnose a lot of abnormalities if we thoroughly examine the tympanic membrane. So the tympanic membrane has two parts. The lower part is known as the pars tensa, and the upper part is known as the pars flaccida. And then you can see the handle of the malleus, and from the handle of the malleus there is a triangular shaped cone of light, which is known as umbo. So whenever we do a otoscopy, there will be a reflection of light from that umbo, and that shows that this is a normal tympanic membrane. So these are various disorders of the pinna, the external ear, and all these can be treated, are to be treated surgically only. There is no medical treatment for this. So you have something which is known as a bad ear, where what happens is that, like I showed you, that Y-shaped antihelix, the superior crust and the inferior crust, that is not present in a bad ear. So you have just the helix, and there is a big flat part in the upper ear. So that the surgical treatment is that we make an incision behind and make sutures, and we create that Y shape. So we create an antihelix, and that is the treatment for the bad ear. something called microtia, where the entire external ear or the auricle is not developed or developed in not sufficiently. So that is a condition called microtia, and sometimes there is total absence of the auricle, that is known as anotia. So again, the treatment is surgical treatment, where the entire external ear with the cartilage, we take cartilage from various parts of the body, from the rib, from the iliac crest, from the nasal septum part, and we can create and fashion the auricle. Then there are certain things which are known as the pre-auricular tags and pre-auricular sinuses. So these are all embryological abnormalities. The patient is born with these disorders. So again, the treatment is just surgical. There's no cause for any medical treatment in there. So these are embryonal deficiencies. So the auricle develops during the 6th week of gestation, and it develops from the first and the second brachial arches. So there is a mesenchymal deposits which are known as hillocks of His. So there are 6 hillocks of His, and 3 will develop into the helix and the antihelix, and 3 will develop into the lower part. So any abnormalities or in the fusion of those 3 upper and 3 lower hillocks of His will lead to the formation of this pre-auricular tags and pre-auricular sinus. And sometimes this, if there is a sinus, it can be a discharging sinus also, which if there is a lot of discharge, a lot of pus, can be initially treated with antibiotics, but then you have to excise that sinus tract. Again, a few disorders of the pinna which are again, like I said, treated only with surgical intention. So this is known as an auricular hematoma, usually caused because of trauma only. So all these rugby players, wrestlers, pugilists, they will have this trauma to the ear. That's why they wear those headgears, and they will always cover the ears also. Because what happens is, like I said, the auricle is, the upper part is called cartilaginous, and it's covered with the perichondrium and the skin. So what happens, whenever there is any trauma, there will be collection of blood between the perichondrium and the cartilage, and this is a very quite painful condition. We have to release that clot, or if it is infected, we have to do an IND. And because of that, what happens that the skin becomes like a cauliflower. So whenever we see a cauliflower kind of ear or the auricle, we realize that yes, this is because of repeated or some trauma in the past. So again, the treatment for this is surgical only. Another case in point is a keloid formation, which is again because of some trauma or piercing, because keloid is your own body's reaction to how the healing process occurs. So this is extra healing and extra formation of the skin. Again, the treatment is excision, but keloid usually are prone to recurrence, and some people initially when we use cold blade, used to inject corticosteroid in the excised area so as to prevent the recurrence. But what I have realized, and so many doctors, researchers before for so many years, that if we use something called laser, we use a CO2 laser to excise this, then the chances of recurrences are very less. And I've got an entire series where I've done laser excision for the keloids, and we've got very good results. Now,
there are some few children, those who come with the ears, which is little bit externally placed and out.
So that is called a back ear. Back ear, and that is because the scapha is not formed. So if initially in the first up to 5 years of age, we say that it might resolve or it might form on its own, but after 5 years of age, if it is still there, then you have to go and do a surgical correction of that. If the parents are...
What kind of hearing?
Hearing is not, no.
Hearing is a cosmetic problem.
It is more of a cosmetic problem. But yes, hearing has to be checked to see whether there is any sensory neural component or other conductive loss also. So external, again, ear canal, external auditory canal infection. So this is furunculosis of the ear canal, which is known as otitis externa, mainly because of streptococcal and staphylococcal infection of the skin, because it's all skin, and the external auditory canal is around 2.5 centimeters or 25 millimeters long. It is lined by normal skin, so it will have sebaceous glands, it will have ceruminous glands. So cerumen is the wax forming gland. And any trauma, repeated cleaning of the ear might cause this kind of infection. So again, the treatment, medical line of management, antibiotic analgesics, and sometimes it can be associated with middle ear infection. So we have to see for that whether the middle ear is also involved or not. Like I said, the external ear is lined by skin, so and there is ceruminous glands, so there is always formation of wax. Now wax is either it can be dry or it can be wet kind of wax. Usually the Asian group has more of a dry kind of wax formation. So that is our genetic predisposition. And if there is any wax in the ear, what we do is we try to remove the wax, or if it is impacted, if it is hard and impacted, then what we say is we advise wax softening eardrops, and once the wax becomes softened, it can be removed easily. Initially, a lot of doctors used to do ear syringing. Now it is no longer practiced. At least I don't do. I am not following that syringing at all. Another condition of the external ear is otomycosis or fungal infection. Whenever there is any fluid or water or going into the ear, it can cause some fungal infection of the skin and maybe something fungal deposit on the tympanic membrane also. Again, the treatment for this is cleaning of the ear so as to remove whatever fungal debris is there, and then we instill antifungal ear drops and it can be resolved.
How common is this fungal infection?
Very
Most of the time you see
very common.
prescription OTAC ear drops, when patient comes.
So actually it has to be seen.
In a normal individual it is common, it is in a immunocompromised.
No, not always. In immunocompromised patients are more prone to develop fungal infection, but it's very common in normal patients with normal immunity also. It's only associated when there is a lot of fluid or water going into the ear and it is not dried up. So people who shower a lot, go for swimming, sometimes get wet in the rain, they will have. So rainy season, those 2-3 months we see a lot of fungal infections. And the best treatment for that is we have to clean the ear, we have to mop it. It's called dry mopping of the ear. So you clean the ear thoroughly and make it dry. And then we instill ear drops so as to prevent any further fungal hyphae from forming. So going in from the external ear, and I am going to the middle ear. So this is middle ear traumatic perforation. Again, it has to be seen. For diagnosis of a perforation, you have to examine the ear, do an otoscopy, and then only you will be able to see whether it is a perforation or not. Whenever there is any trauma, somebody's got hit or a fall can lead to this kind of traumatic perforation. And how do we diagnose a perforation? Because a traumatic perforation has very rad kind of edges and there might be some bleeding around in the vicinity also. So the treatment for a traumatic perforation is should be no ear drops. You have to keep the ear dry. Keep it dry, no ear drops. Just give antibiotics if you feel that patient may develop some infection, or you give just painkillers and antihistaminics, and within 3 to 4 weeks it will heal on its own. If some trauma is associated with a loud sound, then we have to examine for any hearing loss also.
The perforation also gets naturally corrected?
Naturally corrected if it is a small perforation, it's very small, it is recent, you have diagnosed it within a week, you have started the treatment immediately, there is no associated infection, then it is said that within 3 to 4 weeks or maximum 6 weeks, that perforation will heal on its own. But there will be some sclerosis, so that if an ENT surgeon sees the tympanic membrane, we will be able to distinguish whether there was any previous perforation and now it is a healed tympanic membrane. So that we will be able to distinguish.
Beyond what measurement it will not heal naturally?
So if it is, the lower part of the tympanic membrane is divided into 4 quadrants. Okay, so if it is going from more than one quadrant, then we say that it will not heal on its own. So it's very small, just involving just one quadrant of the ear, so less than 25% of the parts tensor, then it will heal on its own.
So basically around 3-4 millimeter or more than that probably
Less
might
than
not.
that. So disorders of the middle ear, acute suppurative otitis media, this is called ASOM, and many of these patients would be coming to you for treatment because they will have fullness of ear ache associated with some rhinitis, upper respiratory tract infection, and earache. So there are various stages to the acute suppurative otitis media. These are all otoscopic findings. So without seeing the ear, you will not be able to diagnose whether it is a acute suppurative otitis media. So there are various stages where it's called, first stage is the tubal occlusion, when the eustachian tube is getting blocked. Then there will be a pre-suppuration phase, then a suppuration phase, and then there will be a discharging or a resolution phase. All these acute otitis media conditions can be treated medically with antibiotic, analgesic, antihistaminic, nasal decongestants, and then regular follow-up. So there is a role of surgery in such cases where what we do is we put an incision in the tympanic membrane and we release the pus which has accumulated in the middle ear, and that is the surgical technique is known as a myringotomy. So yes, this is a condition which can be treated both medically and surgically. Disorders again of the middle ear, we have something which is known as a serous otitis media, glue ear, or it's also known as an otitis media with effusion. So these are insidious in onset, or it can be long-standing for more than 3 months. There is associated ear loss in this case. There is occasional, very occasional otalgia. So patient will not complain of much pain, but there will be a very significant hearing loss. And this condition, and there is something which is known as echolalia. So patient feels that his own sound is echoing in his ear. So that is a very significant symptom which the patient will say. And there is some bubbling kind of sound also coming from the ear in which the patient will feel. So again, treatment for a serous otitis media is, you don't need antibiotics for this. You just need corticosteroid, antihistaminics, nasal sprays, oral decongestants. We ask the patient to keep on chewing gum, or keep on chewing or yawning, blowing balloons, so as to open the eustachian tube, because there has to be air behind the tympanic membrane. So how the sound gets conducted is through the medium of air. So in our external ear there is air, then there is a tympanic membrane, and behind the tympanic membrane in the middle ear also there has to be air, and that air comes from the eustachian tube. So your posterior, the nasopharynx is connected to the middle ear through the eustachian tube, and the eustachian tube brings in that air behind the tympanic membrane. So whenever that air gets blocked, whenever the eustachian tube is blocked, so there will be a formation of vacuum in the middle ear. So that will lead to creation of that serous discharge. Okay, so that is what serous otitis media is there. And here the main considerations are whether we see why the eustachian tube is getting blocked. Is it because of the adenoids which are hypertrophied and blocking the eustachian tube? And if that is the case, then we would always advise adenoidectomy or adenotonsillectomy. What we can do here is a surgical treatment also, which is known as Grove incision. So you put a tube in the ear so as to create that air presence in the middle ear. Now going from acute to chronic. So chronic otitis media is also known as chronic suppurative or CSOM. Again, there are two types of CSOM. One is a mucosal and one is a squamous. So mucosal is, there is perforation in the tympanic membrane, and this mucosal perforation or mucosal otitis media can be active or it can be inactive. So active is when there is ear discharge, And inactive is, it's in a quiescent phase. So there is no ear discharge, but you see a perforation in the tympanic membrane. And another thing is the chronic otitis, a squamous kind of chronic otitis media, where there is presence of a cholesteatoma, which is a squamous debris formation, and or there is a retraction pocket formation. Treatment again is you dry the ear first. That is the most important thing. First you give antibiotics, ear drops, antihistaminics, and try to dry the ear, and then we operate it. So if it is just a tympanic membrane perforation, what I would do is a tympanoplasty, and if there is a cholesteatoma, then there would be a bigger surgery where we would remove the cholesteatoma sac, remove the eroded ossicles, remove the bone which is involved. So that is known as a mastectomy. So there are various types of mastectomy depending on how much involvement of the bone and the ossicles are there. So what we commonly do is a modified radical mastectomy. Then there are various techniques how you do that modified radical mastectomy. It's an inside-out technique, or you do a canal wall down technique or a canal wall up technique. So there are multiple techniques of how we perform that mastectomy. I will just tell you what this is. Won't go into much detail of tympanosclerosis and otosclerosis. Like I said, whenever we see a eardrum, and if we see something like this whitish healing part of the tympanic membrane, this is not a tympanic membrane, a normal tympanic membrane. It's a healed drum, and there is sclerosis of the tympanic membrane. So that is known as a tympanosclerosis. And from that, what we can gather is that patient had some kind of acute otitis media or a chronic otitis media in the past, which has now resolved, but it has caused sclerosis of the tympanic membrane. And there is something which is known as otosclerosis. Again, here it is the sclerosis or the fusion of the three ossicles. So behind the tympanic membrane, there are three bones, which is malleus, incus, and the stapes. And like you know, stapes is the smallest bone of the body, which is present in the middle ear. So whenever those three bones or the ossicles fuse together, it is called sclerosis, and that it is known as otosclerosis, which will cause a lot of hearing loss and tinnitus. So tinnitus is a main complaint in otosclerosis, and again treatment of both this condition is surgery. Sensory neural hearing loss, and this is something which I want to talk is sudden sensory neural hearing loss. So whenever a person is exposed to a very loud sound, there will be a sudden loss of hearing in that ear. So it is mainly noise induced, and it can be sudden, and it is usually unilateral. So what we do
that
is,
just happened to Alka Yagnik, I guess, 2 months back.
yes, and she has that sudden sensory neural hearing loss because of a very loud sound. So what we do,
I have one question about otosclerosis. Can you throw some lights on the epidemiology of otosclerosis? Because I suppose that is very common in middle-aged female, and they do
Yes.
turn up in medicine OPD as well.
so whenever it happens, the patient will develop tinnitus. So whenever the ossicles start fusing, it will happen with the incus fusing with the malleus. So there will be a high frequency sensory hearing loss. There will be certain cases where there will be a mixed kind of hearing loss, where there is a conductive element also and a sensory neural element also. So if you see the patient where there is a conductive hearing loss or a mixed hearing loss, that is the best time to operate the patient, because then you can give the best results. But if it develops into a pure sensory neural hearing loss, then we usually don't advise the patient to go for surgery, which is stapedectomy, because then already the sensory neural component is on a much larger scale. So just removing the ossified or sclerosed ossicles and putting a piston there will not help in the hearing if it is a high frequency sensory neural only component. So if what we have to do when we evaluate patients with otosclerosis is we do a pure tone hearing audiometry, and we do a impedance hearing audiometry also, and we determine which is the major component, whether it is a conductive, pure conductive, mixed or a sensorineural, and accordingly advise surgery or not to go for surgery and just use a hearing aid.
So autosclerosis is purely age related, or is there any
No,
other etiology as well?
it's not age related. There are certain genetic predisposition to it also, so it can run, you can inherit it also, but it is not always genetic. There are certain components. It's not exactly the origin of autosclerosis is not very well elucidated, but it can have some genetic predisposition.
So as far as I remember, it generally occurs in the fourth decade of,
yes,
is it like that?
The late 30s, early 40s, and because the timing also is important, and whenever we examine the patient after, like if the patient is having a perforated ear, it's just a conductive hearing loss. But if the patient is more than 55 or more than 55, I would not even advise tympanic membrane grafting, or because after the age of 55 the healing will be very less. So even in the best hands, even if I do a perforation grafting, then the results are not so good. Okay, so whenever we see a perforation, even if it is in the 30s, in the 40s, we would ask the patient to get it operated immediately. Don't wait for your 50s to get operated. Similar is the case for autosclerosis. If we diagnose it, we should advise immediate surgery if it is possible. You don't want the sensory neural component to creep in, and then it's not worth doing the surgery.
So is otoscopy is only needed for diagnosis, or you need both audiometries also to confirm it?
Audiometry is a must.
For diagnosis also?
Yes, yes.
As the age advances, the percentage of patients who develop deafness are increasing. What was that?
So as our age advances, after 65 to 70 years of age, as happens in the eye also, the lens, so you have cataract formation. Even in the ears, there is something which is known as presbyacusis. So your the vestibulocochlear nerve, the nerve which transmits the sound. So that nerve at some points, at certain frequency, it is not able to pick up those sounds. Okay, so after 70 years of age, slowly your hearing might get reduced. So it's always better to do after 70 years of age, we would advise the patient to go for a yearly or a 2-yearly or audiometry examination if you have any hearing problem. Because hearing is something where if it is one-on-one conversation, like just now I am speaking, everybody will be able to hear all the human speech, the words at various frequency very clearly. But any person, if has a minor sensory neural component which happens with age-related problems, so whenever there is a group of people talking, they will not pick up certain words. So if you don't pick up certain words in a conversation, the entire conversation will be lost to you. What people are speaking, તમને ખબર જ નહીં પડે કે આ શું વાત ચાલી રહી. You will pick up the sounds, but you will not pick up the words. So whenever a patient says कि મને બધા બોલે છે તો મને બે વાર પૂછવું પડે છે, I am not able to pick up certain sounds. Whenever we are in a group, I can't add to the conversation. This is the time, and if the person is more than 70, yes, you evaluate, do an audiometry, and advise a hearing aid.
So madam, that sensory neural hearing loss is very well defined in diabetic neuropathy as well, or
Yes.
what's the epidemiology there?
Yes. So diabetic neuropathy, so peripheral neuropathy, it happens very fast, and in diabetic patients, it is very commonly seen that the nerve, the vestibulocochlear nerve, is the first nerve to be involved. So diabetic patients will have a more earlier onset of a sensory neural hearing loss. So moving on to the nose and paranasal sinuses. So the nose is the most important part of your body. Whenever somebody sees you, the first thing which happens is your nose. That is the first thing anybody will see you. Then comes the eyes, then comes the lips. So the nose is the center of your face, and that is the first structure of your body which will be seen. So it's extremely important important both aesthetically and functionally. So first is any deviations of the nasal framework. So the nose and this part of the face, there are multiple small bones. So you have the nasal bone, you have the part of the maxilla, you have the part of the palatine bone, you have the sphenoid bone coming from the back, you have the frontal bone. So all the bones fusing together and forming the nasal framework. So there will be certain external nasal deviation, there will be deviations of the septal cartilage and the septal bone, which separates both the nasal cavities, and there will be something which is known as a combined deviation. So it is important to differentiate between a constant block because of the deviated nasal septum versus whether it is a seasonal or an intermittent blockage because of any allergy. And if there is any associated headache, fever because of the allergic or acute rhinosinusitis. So again, conditions where you have nasal blockage, you have to see whether it is because of an anatomic problem or it is a pathological or a allergic problem or a infective condition. So if it is just because of anatomic deviation, then the treatment is rhinoplasty or a septoplasty or a combined thing where we do a septorhinoplasty. We don't just make the septal cartilage come into center. The external deviations are also cleared. So that is something which is known as a combined septorhinoplasty. Nasal bone fracture is extremely common whenever there is a head-on trauma, vehicular trauma. So we have to look for associated maxillofacial injuries and injuries to the skull, spine, chest extremities, and the normal management ABC of trauma is done. And we have to manage the nasal bleeding if it is active. And if there is any nasal bony fracture, it has to be reduced in the initial 12 hours. And if the patient comes after 12 hours, then we wait up to 3 days for the swelling to reduce, and then we do the nasal bone fracture reduction. Another very common condition in diabetic patient with nasal vestibulitis. So the anterior part of the nasal cavity is lined by skin. So there are hair follicles, and any infection, staphylococcal infection of the hair follicles will lead to this nasal vestibulitis. Why it's so important is because it involves the danger area of the face, which is a triangular area coming from the bridge of the nose up to the angle of the mouth. So this entire triangle is very important. Any infection there will immediately or if untreated can cause cavernous sinus thrombosis, which is a life-threatening condition. So even early onset vestibulitis, if you see it, treat it immediately, go very strong on the antibiotics and treat it. Intranasal polyps, again we have to differentiate. If anybody sees the nose as a just lift the tip of the nose and see, what you see actually is the turbulence. So many times somebody says, oh, he's got a polyp. No, it's not actually a polyp. What you see immediately will be a turbulence. So there are there are three turbulence: the inferior, the middle, and the superior turbulent. And what we actually see immediately when we lift the tip of the nose are the inferior turbulence. And most of the time, the inferior turbulence are hypertrophied. So what we see are the hypertrophied inferior turbulence, which are sometimes mistaken to be polyps, but they are not actually polyps. Polyps will be seen only when you do a anterior rhinoscopy with a speculum, or you put a scope inside and you examine. So again, it is if there are polyps, treatment is surgical line of management. So we have to differentiate whether it is a ethmoidal polyp or it is a maxillary sinus polyp. Again, if it is a maxillary sinus polyp, it is unilateral. It's called an anthropoidal polyp, and usually there will be larger and congested mucosa. And if it's a ethmoidal polyp, it will be bilateral, usually pale mucosa and multiple polyps. Okay, so medical polypectomy, there is a line of management for the ethmoidal polyps because they happen because of allergic problems. So you can give a short course of steroid, you instill corticosteroid nasal sprays, even oral antihistaminics, 4 to 6 weeks of course we can do. But But if the patient is not responding to it, then the only management which is left is a surgical line of treatment. You do a polypectomy, and now what we do, initially it was just polyp removal, but now with the advent of scopes in the last 20-25 years, what we do is it's known as a functional endoscopic sinus surgery. So you maintain the normal physiology of the nasal cavity. You don't interrupt the ciliary drainage of the various sinuses. You are just removing the polyp. You are opening the meatus so as to help in the drainage. So that surgery is known as a functional endoscopic sinus surgery.
That first picture was also hypertrophied turbinate.
This is the hypertrophic turbinate.
First is also hypertrophied.
Yes. And then the second one where you see the turbinate and then in the shadow you see something.
Yeah.
So that is a polyp.
Okay.
This is actually a polyp, but this is anthropoidal, the third picture. It's an anthropoidal polyp, unilateral, okay, coming from the maxillary sinus. And the fourth picture, the whitish thing, so these are all ethmoidal polyps which are large coming up anteriorly.
Oh.
Allergic rhinitis, very common. Always you will have few patients every day coming with this problem of allergic rhinitis. So it is paroxysmal sneezing, watery nasal discharge, itching of the nose, eyes. It can be seasonal or perennial, has some genetic predisposition, often associated with other atopic manifestation, can progress to sinusitis if it is not treated. So treatment is avoidance of allergens. You can get all the allergic testing done, and if it is a food allergen, you can avoid it. If it is dust and mite,
कितना बाकी है मैडम?
I'll go fast.
अगर ज़्यादा है तो आप next Wednesday कर दीजिए क्योंकि 9:30 हो गए.
Okay, so I'll just finish the nasal part, and the throat part we can do next. So allergic rhinitis, you just avoid the allergen. Intranasal corticosteroids, antihistaminic sprays, all these are used. Fluticasone, ezilastin, oral antihistaminics. You give a course of 3 to 4 weeks, and Montelukast most commonly used along with the antihistaminics. So what I want to specify in this is whenever we use this decongestant sprays, it should not be used for more than 2 weeks. It should not be used for more than 2 weeks because it leads to something which is known as rhinitis medicamentosa, which will cause a reverse effect. It will cause more nasal blockage. So not more than 2 weeks of decongestant sprays.
Now, how frequently are you able to cure allergic rhinitis?
First and foremost, we will not be able to cure allergic rhinitis at all. Nobody can cure it. We can just control it. We can control it. We can give things to boost the immunity of the patient. So even if the allergen is present, he or she will not have such severe symptoms.
The point is, ultimately everybody lands up in doing allergic tests.
Yes.
Okay? So there are allergic tests, you find that 10 are very common. 10 are very common. Whether that patient is having allergy or not, whether he will avoid or not, that are present. So how see? Now my point is, it is I think it is difficult to treat allergic rhinitis.
So acute symptoms you can clear immediately, but persistent होए, sneezing. So get up in the morning, 8-10 छींको आ गई, पानी निकलने लगी, then over a period of few hours it will subside on its own. So what we are treating is we are preventing it to go further, allergic problems developing into polyps, developing into chronic sinusitis. We can avoid that, but we will not be able to cure that allergic rhinitis totally. We can control the symptoms, make it milder form, and we know if it is allergy, there will be certain episodes throughout the year where the patient will have more of these problems. So we tell them that
is February. February comes.
February, September,
So
October.
about 6 weeks.
Yes.
People will have lot of sneeze.
Yes.
Spring and autumn.
Spring and autumn. Yes.
immunotherapy, you know.
Yes.
So what is the role of immunotherapy?
Immunotherapy, like I said, it will improve your immunity, make your body stronger. So whenever, even if the allergen is present in your environment, your body's reaction will be on a milder level. It will be there. It will not go away totally.
I don't think routinely anybody would prescribe immunotherapy. That is what he is asking. What is the role of immunotherapy, whether you...
In severe conditions, yes, you can try, but it is always seen that severe allergic problems, you can give a short course of steroid, and patient usually includes systemic steroids. And then you have your nasal sprays, which are local, so that has a good control also.
So allergy is that condition that the saying holds very true is prevention is better than.
But 100% prevention is also not possible, because after all, the air we breathe is common for everyone. You can live in
simple measures કે hand wash છે, તમારું handkerchief છે, mask છે, આ લોકો બી ફોલો નથી કરતા. મને તો થાશે જેમ કરીને હાલે રાખે બધું.
that hand washing, cleaning, do not keep on rubbing your nose. If you just follow those basic hygiene principles.
The commonest, you know, you in allergic place to find is the animal dander.
Yes.
In India, animal dander is so common, becoming dust, you know. There are so many dogs, so many cows, so many buffaloes, so many, you know, cats. You know, and that getting, you know, dried up and getting.
I always tell my patients that instead of you getting your own body tested, which allergens, you get your air tested. તમારા ઘરની એર, તમારા એન્વાયરમેન્ટની એર છે એનું સેમ્પલ લઈને પહેલા એ ટેસ્ટ કરાવો કે એનામાં કેટલા અલર્જન છે, and then you try to avoid that. I think that will be a better answer.
Another common is this, you know,
Kabutara droppings.
See, every house he will have, you know, that dropping.
Yes, yes.
And that is responsible for not only sneezing, dry cough. It is difficult, you know.
And it is so irritating, and people get sick of it. Not just the patient, everybody around.
So as per guideline, there is no role of allergy testing, or there is a role.
There is a role if the patient wants, if it is severe, you want to rule out certain things. Certain things you will be able to say offhand. धूल में नहीं जाओ, crowded places में नहीं जाओ, avoid all your pulsars, avoid all these legumes. This is very common.
But guidelines do suggest to do allergy test?
No, I mean American guidelines will suggest everything. They suggest and they do also all the tests. But practically speaking, I don't think it counts.
No, the thing is getting an allergic test done. If you are not going to avoid it, so it is not going to be helpful, because there is no way you will be able to avoid. You know, all the dust and pollen and this thing which you all get every day outside. It is very difficult.
Now people living in Delhi, because of such poor air quality indices, everybody is having problems.
Forget Delhi, madam, you go to Baili at night, તમે 7:30 Baili માં બેસો ખાલી ચોક પર, you will realize that AQI will be 300, 400 very easily.
Right.
Other is the common usage of nowadays deodorants.
Yes.
Deodorants, spray. You comment, you come in contact with those, even my nose starts irritating, you know.
Yes.
So how can I prevent? I ask them to, even patient comes with, you know, spray here and there and then seat in front of you. I cannot ask him to chop those best.
So
I always tell the next time when you come, don't apply.
Next time they do 9:35.
Okay, I'll continue next week if possible.
હવે સાહેબ આપણે ચાંદ પર પ્લોટ ગોતીએ છીએ, હવે ત્યાં શિફ્ટ થઈ જઈએ.